Great. Well, April is Sexual Assault Awareness Month, and we wanted to talk today on Research to Practice on the intersection of COVID, race, ethnicity, and sexual assault. My name is Jae Dee Wood. My pronouns are she, her, hers, and I'm here to moderate a conversation today. I'm here with the Injury and Violence Prevention Center. I want to talk a little bit today about our speakers. We have someone from the nursing field, Foote-Lucero. Christine, do you want to tell us a little bit about yourself and your specialty in sexual assault?
Sure. My name is Foote-Lucero. I've been a registered nurse for 21 years. Most of that was in the emergency department and the intensive care unit. And then also since 2010, I have been a forensic nurse examiner. And I'm currently the nurse manager of the forensic nursing team at the University of Colorado Hospital.
Thank you, Christine. I also have Sergeant Mary Prestel. Mary, do you want to tell us a little bit about your background as well?
Sure. Can you hear me okay?
Yes,
Okay.
Great.
I've been with the Denver Police Department for actually be 25 years this June. And for the last 5 years, I've been the sergeant in the sex crimes unit where I supervise 10 detectives.
That's great. We have a lot of experience in this room. My name is Jae Dee Wood. I work as a community-based advocate who helps survivors of sexual assault, whether or not they report to the police or the hospital. Our role is to really connect survivors with resources and help them make the safest decisions for them. These resources can include emotional support, support with the court process, information. We link survivors with therapy, referrals, sometimes rental assistance, and help them holistically heal. I've been doing this work for 5 years and am currently pursuing my master's in MPH. I do want everyone on this webinar to know that there is help for survivors of sexual assault. We will be talking about sexual assault. So if you need help, whether you're in Denver, Colorado, or anywhere in the US, you can call 1-800-656-4673 for support for sexual assault if you or someone you know needs support. Today, we are going to be talking about sexual assault and medical forensic exams, sexual assault and COVID, sexual assault and race, and then talking about some results from our different fields and some preliminary analysis on race and some discussion. I do want to note here that we will all be using a little bit of different language. I might be using the word survivor, while someone else might be using the word victim, client, patient, or person who did not consent. Survivors themselves use varied language around their identity, and as we all work in different fields, this vocabulary will change. And we're going to also talk about sexual assault and SANEs, or medical forensic exams. Sexual assault is any unwanted sexual content without verbal, enthusiastic, or freely given consent and can be withdrawn at any time. It can include a variety of behaviors from rape to non-consensual oral sex, non-consensual touching for sexual gratification, and varies by state. And I want to pass it off to Christine to kind of talk about SANEs and medical forensic exams.
Thanks. So the medical forensic exam is a medical exam that a specially trained nurse called a SANE or an FNE would do. The only distinction there with terminology, a SANE will specialize only in the sexual assault arena. And then FNEs, or forensic nurse examiners, will see any patient affected by violence, but that does include patients affected by sexual assault. And then other things like human trafficking, child abuse, elder abuse, things of that nature. The medical forensic exam, the #1 priority for that is to ensure the patient is safe and healthy medically, and also to restore control to the patient. That is super important because during that sexual assault, control was stripped from them. And so allowing the patient to have that sense of control back is really important. These are always going to be trauma informed. We are going to explain every step to the patient. They can choose what steps they do want to do or not want to do. But again, the priority is that medical care. All the nurses are trained in evidence collection. So as they're performing their medical assessments and healthcare, they can also collect swabs or any evidence that they feel is pertinent to the case. And then, of course, they have training and expertise in how to seal, store, and hand over that evidence. We are also experts in reporting options, so we will spend a lot of time with the patient making sure they understand what those options are depending on their age, and then what each of those options could offer them. We also do a lot of safety planning, connecting them with resources such as victims advocates, whether law or community, connecting them with crime victims compensation, even things like counseling services and things of that nature. And then all the nurses have done extra training to be expert witnesses in court. So we're not only providing, hopefully, providing improved healthcare outcomes, but improved legal outcomes for these patients as well.
Yes. Thank you. And speaking of those legal outcomes, Sergeant Prestel, can you please comment on how these sexual assault nurse exams or medical forensic exams are helpful to the investigation for the police?
Of course. So as I learned when I first got to this unit, I quickly have appreciated so much all of the SANE nurses that I've worked with at both hospitals, mainly University and DHMC, because for sex assault investigations, the evidence collected during the SANE exam, in my opinion, in most cases, is the most important evidence that we do collect. So the huge, importance placed on SANE exams and how well that university and the other hospitals handle it have just been so tremendous in assisting us with our investigations, for sure, because so much of it depends on DNA, of course.
Mm-hmm.
I know when I first got here, they were working on trying to speed up the results of SANE exams. And that's a constant that our lab is working on in CBI. It has gotten quicker, but I do wish that SANE results and DNA results came back faster than they do presently. It's anywhere from, it varies. I've seen it come back in 3 months, and I've also seen it come back in 9 to 10 months. So it just really varies. I know that our Denver lab has to prioritize certain crimes, and sex crimes are certainly a priority, but there are other crimes that also take precedent too. So, but we also have the ability to expedite SANE exam results. So that's nice too. If it's a public safety issue or a serial pattern issue, we can certainly do that. So yeah, I can't stress the importance of the SANE nurses and the SANE exams, because that really is like the key piece of evidence in most of our investigations.
Mm-hmm. So SANE exams have become a huge tool for survivors and law enforcement to really reach their goals. And we are very lucky that this program has grown so much. We had COVID in 2020, and this did not mean that lockdowns prevented sexual assaults. We know a lot of things about sexual assaults, including sexual assaults 9 out of 10 times happen between someone the client or victim knows. We also know that sexual assaults within relationships are a common form of intimate partner violence. Even though there's less chance of meeting new victims for perpetrators in bars and restaurants until reopening, we know sexual assaults were still happening. Also, emphasizing the importance of SANE exam, because of lockdowns, there were less witnesses out and about to report sexual assault as witnesses to a crime, and maybe less opportunity for healthcare in general due to the healthcare surges. Christine, do you have any comments on what you kind of saw in the field during 2020 for medical care at this time?
Yeah, it was interesting because when we first started hearing about COVID, there were so many unknowns. We didn't know, we didn't have a lot of information about how it was transmitted, right? Do you wear fabric masks or no fabric masks? There was a lot of misinformation coming out. And I think just the general unknown, we did definitely see lower numbers of patients coming to the emergency department, which is where our forensic team is based out of. And I think a lot of that too is, the fear of that unknown. If I go to the hospital, can I get it? Will I get sick? Is there someone else there with it? So generally speaking, just across the board with emergency department volume, we definitely saw a decrease.
Mm-hmm. And then Sergeant Prestel, for people reporting crimes to police, did you notice any trends during this time of people contacting the police when they needed help for sexual assault?
When you had first asked me to look at this, I was surprised myself with the results, but yeah, we definitely saw sex crimes in general, which includes everything beyond sex assault too that we investigate, indecent exposures, unlawful sexual contacts, just sex crimes in general. We definitely had a decrease during COVID and when, you know, schools were closed and bars were closed. And then as a result of that as well, our SANE kit collection and what was actually placed into property, we definitely had a significant decrease in SANE kits as well.
And some of that data she's referencing, we will show you in a little bit. We also know that there is sexual assault and racial differences between race. Sexual assault victims are disproportionately people of color. When we look at this graph, when we're looking at all victims, white victims, Black victims, other and Hispanic, the numbers look highest for white, but when you look at that in proportion with the population, we see that people of color are disproportionately affected by sexual assault as victims. Also not included in this graph are Native Americans, who are most at risk for sexual assault. They're 2 times more likely than other races to report sexual assault. But we do know that there is sometimes an issue with data collection of identifying these people or them self-identifying themselves. So right now we are working on a lot of different data projects around what happened during COVID for victims of all violence. But today we wanted to talk about victims of sexual assault who sought evidence collection through the Colorado forensic nurse exams between 2019 and 2021. I want to make sure everyone remembers there was a lot going on in 2020. There was a lot of contextual things that happened. We had a few different SANE sites that closed in Denver in the years before. There were multiple COVID lockdowns and reopenings with different restrictions every time. We had an increase of Asian hate crimes from the verbiage around COVID, people calling it the China virus and other things. We also had the deaths of George Floyd and Breonna Taylor and political elections. So we do have a lot of things going on in 2020 when we look at some of this data that could have affected who was coming forward, who was sexually assaulted, and who was asking for help. And this data is from Sergeant Prestel, if you want to kind of talk about some of these numbers that we saw in the changes here.
So one of the things I was interested in, of course, knowing the percentage, I think the most recent data is like 80 to 85% of sex assault victims know their perpetrator. So, you know, it suggests for sure the social opportunities. So with bars being closed, restaurants being closed, that certainly limited a perpetrator going out and, you know, finding or meeting with their next victim, and as well as schools too, with colleges having limited capacity and K through 12. So when I pulled the data, I kind of did it around the dates that the governor had ruled when bars were to be completely closed, and then at some point they were open with a partial capacity, and then they were closed again, and then they finally reopened completely. So looking at this, you can certainly see that that March, June, that orange bar in 2020, the cases and SANE kits were definitely way down. You know, whether that's a direct correlation, like I said, not necessarily with bars and schools, but I do think that does produce or introduce a social aspect that has to be considered when we take a lot of our sex assault reports. A lot of them do start in the social aspect, whether they meet someone at a bar or a restaurant, or they know someone at school. So that's why I had looked at that.
Yeah, and we definitely do see a dip in the 2020 bars for both March through June and July through April. So it's important to note that all of these things that happened in 2020 did affect numbers of SANE kits that we were seeing. And then it looks like they go back to almost the same level in 2021. This is data that we have from medical forensic exams from the University of Colorado Hospital, or UC Health. I do want to show that there is a few different bars here, 2019, 2020, and 2021. And then for 2022, we wanted to include this because of the police data, including 2022 through April. Christine, do you want to talk about some of the things that were happening in these years and the changes that we saw in sex assault and medical forensic exams?
Yeah, so I started the program in 2017. And so at that point, we were maybe seeing 20 exams a month and we're on call only. Within about a year and a half, we had enough volume to then qualify to have a forensic nurse in-house 24/7. And then in 2019, we then had enough volume to have another, so we have 2 nurses in-house now during our busiest time. But while we were expanding with our volumes and this program was growing, we also were dealing with some other things in the city of Denver and just even in the suburbs of Denver where other SANE programs or forensic programs were closing due to lack of funding and things of that nature. So our volumes did really start increasing. So I just like to make sure that the data is in that context that we absolutely, our volumes are increasing every year. I think that is multifaceted that yes, and maybe Sergeant Prestel would be able to validate this. I feel like, yes, there is, increase in crime every year, right? That comes with increase in population and things of that nature. But we also are seeing increases, I think, part in that there's more awareness about these programs and that patients realize they have options of where to go and that this exam is something that, that everybody should have access to. So I think just awareness with maybe media and certain things, people are realizing that these programs exist to help patients when they've been assaulted. And then also, I think as we were coming out of COVID, right, people were feeling a little bit safer coming and accessing care at the hospital setting.
Yeah, so a lot of these help-seeking behaviors, such as going to get a forensic exam or going to the police to report a sexual assault, are increasing with a lot of different contextual things. So population and just outreach as well. And just another thing to note on this slide, if I can go back, I'll see if it'll let me, just noting the differences in Denver numbers. The top numbers that we're seeing at 500 in 2019 were around the numbers that we saw in a year for the police data. And then when we look at 2021, it's closer to 2,000, which is almost 3 times the amount of reports making it to law enforcement. So just knowing that those patients have options and they can always change to some of those options later. So these are some of the preliminary results about medical and forensic by race and year from UC Health. We can see that this includes all consults for a medical forensic exam and not just sexual assault because of the way we're cleaning and pulling the data right now. I'm hoping by May 15th that we'll be able to have some really good numbers just on sexual assault. But we're looking at what races are seeking medical care in this diagram. We definitely see an increase on every single race, but we see that white or Caucasian people are seeking the exams at the highest number, followed by Black, Asian, and then virtually no Native American or Alaskan Native Hawaiian or Pacific Islander. We have a lot of other race or multi-racial. So just kind of looking at this in context of Denver and the surrounding areas, we know that the population around that area is about 73% white, and then 9.1% Black or African American, and then about 1% of Native American and 3% Asian. So are these races not seeking medical care? Are these races afraid to seek medical care? Are their outreach in their community and their languages that they speak? And do they feel safe coming forward to make these reports on crime? I wanted to see if anyone had any comments on some of the things they're seeing in this, Christine or Mary.
I will say when you were reading off the percentages of the different racial ethnicities, that was pretty impactful for me because I believe you said 9. What was the percentage for African American? Was it 9%?
9% in the Denver metro area.
That is such a visual to me then to see that in 2021, that the African American patients were not really that much less than the Caucasian patients, even though they make up such a smaller percentage. So to your effect on the earlier slide that it disproportionately affects people of color, this is the visual for that. For sure. I do think a lot of the political climate and things that were happening, you know, certainly could speak to whether people feel safe coming forward. And then also, I think despite what we try to do with community awareness and making sure that people don't feel that like finances are a burden, we know that people that are underserved are not going to come, you know, seek medical care because of the thought of what is the emergency department going to cost, what is this going to cost, you know, and things of that nature. So that is an unfortunate barrier that we're still, you know, trying to get awareness out about, that patients, you know, do not pay for the evidence collection. And we do have many programs in place like crime victims compensation and other things to assist with any types of medical bills.
And then Sergeant Prestel, does anything speak to you on this graph?
Well, I was just going to kind of tag on to what Christine said earlier slide. She's right as far as public awareness and being better about that, because I do notice every year, it's not huge increase, but in April, of course, it's our Start by Believing campaign and Sex Assault Awareness Month. And it seems like at the end of April, May, June, we do see a increase in reporting. And I've often wondered, is that a coincidence, or is that due to the campaign and we're getting it out there for a little while, reminding the public, and they feel more comfortable coming forward. So I know that's certainly an area that law enforcement can work on. You had in one of your slides as well that one of our sites that it used to be called Seek and Speak to Report, is no longer funded by the group that was funding it. That wasn't by DPD, but it was by another group. So that's certainly something, as I look at all this data and realize, during COVID as well, if people didn't feel like they could go out or they didn't feel like they could go to the hospital, I feel like if maybe they had that website at home just to kind of peruse and look through, that might have been helpful. So that's certainly something that sticks out to me too, as far as getting the message out to the community, to all races, all just everyone. I think that would be really helpful as far as increasing reporting.
And you were speaking on a pilot program that is no longer funded, where survivors of sexual assault could go online and make a report and later come back and give more details like their name.
Right. They could either remain anonymous, or they could put all their information in there, and then we would contact them and if they wanted to move forward with the report. And that used to be called Seek Then Speak. And Denver just doesn't have that anymore. But like I said, this is certainly now I am going to look into something like that to do with DPD. I don't see why we couldn't do something like that. So.
Yes, we're always working to find ways to support survivors, even when funding decreases some of the programs, but it sounds like there were some that are worth bringing back, especially looking at this data.
Definitely.
So some of the key takeaways I want to talk about were lockdowns changed a lot of things, and so did 2020. There was a lot of financial hardship for people, unawareness of what the future might hold for income and resources, as well as increased home with perpetrators. We know that they're in connection with intimate partner violence. Increased home at time with perpetrators, financial hardship and isolation are the perfect storm to drum up more domestic violence, including intimate partner violence and sexual assault. There were still opportunities for sexual assault during these times. And as we keep repeating, these services are essential survivors for medical care, connection to support, and legal opportunities. And then we also want to remember that in every time we want to believe and prioritize survivors. We all run 911, 24/7 hotlines, and 24/7 responses for survivors. But during this time, I know a lot of us brought up that we were getting calls from survivors saying, can I even leave my house? Can I get support? Can I go to the hospital for a SANE? Can I leave and make a report of a crime to 911? Can I leave to meet with an advocate to go to a safe house? And these things were all possible, but there was not a lot of outreach on this, or it wasn't reaching the survivors that needed it most. Any other things that pop out on this slide for key takeaways of things we learned during 2020 for survivors of sexual assault? I'm going to keep starting with Christine to stay in order.
Sorry, you cut out just a little bit. Can you repeat that?
Yes, just anything that we took away from 2020 on the lockdowns to prioritize and believe survivors of sexual assault.
Yeah, I would say, the biggest thing, and I know you have this on an earlier slide, that violent crime and sexual assault, it didn't decrease. They were still happening. It's just that the locations they were happening in were changing, right? So instead of maybe, out at bars or public locations, they were happening in the home. And there has been an emergence of literature, that we're starting to see about, intimate partner violence, which can include sexual violence, and what that looked like during lockdowns. Because what was happening is it was still happening right in the home, but there were no witnesses, and it was, very isolated. People didn't really want to leave the house or were told they couldn't leave the house. And so they weren't getting the help that they would need. And so we did definitely recognize that. And then, believing and supporting is always, should be on all of our radar and agenda. It's interesting to me that this is even something that we would discuss, because if we had any other patient population come in, a chest pain, we would never say, well, do you believe your patient? And so, every patient that comes in to seek medical care, whatever they tell us is going on, and the reason that they're coming in to see us is what we take at face value. It is not, our job to say that that's not happening or that we don't believe them or anything like that. So I just like to, encourage everyone to think about that if you came in with any other medical complaint, there's no element of believing.
Thank you, Christine. And that is so true. It all starts by believing. And any other key takeaways from you, Sergeant Prestel?
Yeah, I think, I wish we could get down on this, but when I review every case that comes through the Denver Police Department for sex crimes, and we average about 1,500 cases in a year. And I wonder, part of me wonders with the lockdown, it all became virtual, right? So even therapy services were virtual. Really the only, hospitals were really the only ones, who didn't get to work from home. Even some of my detectives could work from home, on not a regular basis, but I know some of our community advocacy centers, they were shut down. They worked a lot from home. So a lot of the help and support for survivors turned virtual. And in looking at all the cases that I have throughout, the years, I'm just wondering how much access a lot of our victims even had to computers and to access that type of stuff. So in learning a lesson, if we have, a lockdown again, I'm not sure how to avoid that, but I think that's something to consider, because was part of the reason for lack of reporting. They didn't know, because we get a lot of, mandatory reporting as well, and third-party reporting from therapists and from schools. So if they're unable to go there in person and report things, then we're not getting the reports. So I'm just wondering if that going virtual had a big part of affecting our victims and survivors, and just something to think about. And that's why I think a website with DPD in the future, where they could have made reports, maybe that would be one avenue, but we might have to think outside the box and think of other ways, because, a lot of victims who don't have phones, computers, if they're homeless or transient, what do we do? What do we do for that population? So I know when I talked to you, you had asked for lessons learned, and I came up with that, but I don't have the answers to that, but I certainly think it's something we should think about in case, this were to happen again. So.
Yes, and I think we do have a lot of survivors that were able to call and ask for help in the past when someone went to work or someone went to school, or when they went to work and they went to school. And when there's not those chances and everyone's isolated and stuck at home, it's hard to ask for help. And I really like talking about all these creative solutions so we can really reach every survivor. I think we've talked about a lot of this already, but in practice, since this is research to practice, we want to talk about helping the most vulnerable and most at risk for sexual assault. There are less witnesses to crime, so SANE medical forensic exams may be the only evidence that we have to collect. And then for outreach and training, more outreach on SANEs or MFE sexual assault resources during emergency, like Sergeant Prestel was just saying, and different resources that look different for people in different populations, and just recognizing the diversity and inclusion that needs to go along with this. Some limitations. We only have data on people that came to ask for help from the police or medical forensic examiner. So we don't know who isn't asking for help, but we definitely need to be asking those questions. We all work and live in Colorado, and this data is from an urban hospital site from Colorado and people who were able to travel that way. And we also have to look at this contextually. I think we all keep bringing this up, that we cannot conclude that COVID or lockdown alone changed these events as the entire context of things that happened in 2020. We are ahead of schedule, so we are here to answer your questions, talk about resources and anything. If you want to put those in the chat. If you have a question specifically for any of us, please say so we can do that. And
there is a JD, there is a question in the chat. It says, do you know how many Hispanic versus non-Hispanic?
I'm still parsing apart and cleaning that data, so I want to get to that. That is definitely something on my list. But I don't have that in the data set quite yet, Shelby.
And I think we should clarify too that the racial breakdowns that you had, those are based on what the patients tell us. So the registration staff at the hospital ask them. So I just want to make that clear too. It's not an assumption on a third party or anything like that.
Mm-hmm. And then I see Elizabeth Newman, also just people afraid to go to a hospital in that time. So if they were assaulted, they may be less likely to get a kit done. I think we were talking about the fear of going to the hospital and getting sick during that time.
Yeah, and another thing, it was just such an interesting time. We were dealing with a lot of firsts. And I remember for us in the forensic specialty that I had attended a few webinars about a year into COVID that were starting to talk about the possibilities of at-home kits. And it became like this whole new area to think about. Ultimately, it was never recommended from a medical standpoint, just because we do know, again, to go back to what the MFE is all about, it's medical care first and foremost. And so while DNA swabs are very helpful in seeking legal justice, just doing swabs alone doesn't do anything for somebody's medical needs, right? I mean, we want to make sure that someone that's specialized evaluates them and looks for signs of infection, signs of injury, talks to them about possible HIV exposure, updates immunizations. I mean, all these other things, right, that are so equally important, that's part of the MFE. And then also the other concern with an at-home evidence kit was the admissibility in court. Thinking ahead and knowing what challenges that's going to pose in the legal arena. Even when we collect evidence, we have to speak in court to how did we package it? Was anybody else in the room? Was everybody wearing a mask? That the chain of possession was filled out appropriately, right? So the evidence was never not in somebody's possession at every moment along the process. Well, you have somebody who does an at-home kit, and now you have concerns, could there be questions raised that, oh, well, this is someone you lived with, so you could have just put their DNA on this swab. And all those kind of challenges. But again, this was a first for us. We had never had to think like that. And so, you know, I know that at that time, companies were just trying to come out with things that could still, you know, reach patients that couldn't leave their homes. But so I don't know, maybe they'll be able to figure that process out for any other future times that we may go on lockdowns. But, you know, attempts were made to help meet patients where they were at, which could be in an isolated situation at home. But ultimately, nothing can substitute for having an MFE with a specialized clinician in person.
Yes, thank you, because I know so many survivors have questions when they're in that room of different medical questions that while they could maybe swab themselves at home for one thing, they couldn't get those questions answered of when is the best time to test and when are the windows for when this would show up on a test, especially for HIV and other STIs. It's all about the holistic wraparound services that come along with that medical help.
And I am seeing comments in the box, or in the chat box about the hospital. Yes, we do have a separate delineation for Hispanic and Latinx patients.
And it also looks like there's a question about expedited labs. We don't expedite labs if the case, if the victim is not moving forward with a law enforcement investigation.
And I know during this time too, with labs, there were a lot of labs concentrating on COVID testing, and that could have changed some of the result times as well when we're trying to prioritize one thing. It's really important to know.
I do consistently hear from my colleagues in other states and from our lab personnel in the state that Colorado does have one of the faster turnaround times for DNA. So I know that, you know, potentially 3 months can sound like a really long time. It's just not what we see in the media, right? Shows like CSI, where the DNA profile comes back at the end of an episode. That is just not what happens in real life. And as Sergeant Prestel said earlier, these crime labs are evaluating evidence from all crimes, right? So murders, gunshot wounds, everything. It's not solely sexual assault. But yeah, even if we think that is a long turnaround time, it's one of the fastest in the country. I have colleagues in other states who have mentioned to me, you know, you all are so lucky in Colorado. There's also states that don't have the 3 reporting options. So, you know, I think it's double-sided, right? We have a long way to go, but I also feel like we've come a long way compared to other states in this country.
And then I see a question on how do we seek funding to address some gaps in Colorado? There are lots of funding opportunities. I think they're talking about the OVW fiscal year. And I think we all try to prioritize some of these funding opportunities, but they all take time. They're grants, they have limits, and having a 24/7 staff anywhere is difficult to manage, and both police, medical, and community-based advocates somehow do it on limited funding, and we do the best we can for survivors. So I'm not sure what I think King Lee is referring to, but it sounds like there's some more opportunities they know about.
Oh, okay.
I know.
Can I say something? I'm so glad for we have this important session. I listened to Christine's presentation. Today is the 3rd time. I think it's good we have this ongoing discussion. We identify needs and we want to make things better for survivor or even for healthy family relationships. So I wonder, you know, grant seeking process is a way to objectively evaluate the issues and identify to steps to promote some good things and prevent some consequences. So have this been done in the past from the police department or health clinic? can we learn something being done in the past, or there's intent or some plan or effort, because there's the funding, federal funding and the state funding.
So I can answer maybe part of that. I don't, for DPD, I'm not in charge. I can only look into grants, but we have a whole grant, I think, writer who does all of that. And then also through our district attorney's office. But one of the great things that a grant did do was back between, and forgive me for the years because I wasn't up in sex crimes yet, but I think it was like 2012 through 2014 when there was the backlog. And the law came out that the House bill said that we had, to test SANE kits within 21 days. We got a grant to clear out our backlog in Denver, which we did successfully. So that is definitely, that was a really useful way of using grant money. And because of that, to this day, we do not have a backlog in our crime lab, and we probably never will again because we got that cleared up. So I do think grants are a great way to do things. I just, unfortunately myself, I'm not familiar on how to go about or where to find them or, how any of that works. So.
How about Christine? It's great to learn. Mary, thank you.
Yeah, I will say being in the area of forensic nursing for so long, all programs actually that I know of other than ours only exist because of grant funds. And that is what's happened to some of these closures, is that they've lost their grant funding and it didn't renew. We are very fortunate at University of Colorado Hospital, being a part of a very large health system. Our senior leadership is very committed to this program and knows it's the right thing for patients. So regardless of whether, we are a profit turning department for the hospital or not, they are never going to close our program or limit it. So we are very lucky that we are treated like any other department, right? Like cardiac department or the operating room or any other area of the hospital where the staff are not relying on grant funds to care for their patients. And I think that's super important. That is not lost on me. I know that we are the exception, and that is, we're very fortunate, but unfortunately, like I said, the other programs closed because they did lose their grant funding. So it wasn't for lack of trying or reapplying. I think that it's most healthcare areas underestimate the prevalence of violence, right? We know it affects 1 in 3 people, and that's more prevalent, right, than certain cancers and certain types of other things like heart disease, but yet you hear about those things all the time, or see commercials for them, or community awareness things. So I think we all just have a due diligence to do a better job. And there's just still so much stigma around sexual assault, really any kind of violence, right? I mean, intimate partner violence and all that as well, but it is so prevalent. We need to talk about it more. We need to be open. We need to provide a safe space when people come to us, friends, family, and make a disclosure. But yeah, I'm sorry, I'm getting off on topic because I'm just so passionate about that. But to speak to your grant funding, we currently do not have any grants to support our program to keep it up and running. That is something the hospital supports us with. We are actually a part of an elder abuse task force that has grant funding associated with that. And then our medical director is very passionate about helping us with keeping an eye out for grants that would be applicable for us. I know one thing we're trying to expand is our outpatient clinic. So very excited about that because it is the only in the state for adults that we can bring back those forensic patients, reinforce safety planning, reevaluate any injuries or findings they had, continue conversations about advocates and things of that nature. So we would, our goal in the next few years is to grow that. And then I did just see a comment in the chat about what proportion of individuals who have been sexually assaulted seek out SANE exams. Do we have time that I can speak to that, Jae Dee?
Yes, we do. And I also wanted to bring up the inverted pyramid I kept in my pocket slides in case we needed to talk about this.
So is this is in general?
Yes, this does not include SANE or F&E or medical forensic exam data. But we do know that of all victims of sexual assault, only so many report to the police. And despite best efforts and investigations, it's a really hard crime to prosecute. There's usually only the witnesses are the victim and the perpetrator. And then if there is a SANE kit, that might be the only evidence. So we know that of 100% rate, 1 to 2% maybe see a conviction. And I know that's one of the things that medical forensic exams are hoping to address as well. But I don't know how many victims.
Went to the End Violence Against Women International EVAWI conference 2 weeks ago in Chicago. They had a lot of statistics in some of their opening sessions. And what they were saying about sexual assault in general, and I believe that these were international numbers. I'm not sure they were specific to US, but I know that we experienced the similar numbers in the US. It was less than 10% are going to seek medical care, less than 5% report, and less than 2% will ever have a day in court. So, and it's unfortunate because this is definitely an area that needs to be improved. And our district attorneys are very open about that. I mean, I've had many conversations with them where they have said to me, you know, we don't take cases to trial where we believe someone is guilty. We take cases to trial where we believe it can be proved they are guilty. And so that's really difficult when you have a lot of situations, like you said, where there's a perpetrator and a witness and it's one person's word against another. And if there is DNA in the kit, let's say the perpetrator says it was consensual. Well, now they've, attempted to explain the DNA, and it's, you can just see why these are so complex and difficult. So sometimes a guilty verdict in court is not, we have to be really clear with patients that that's not necessarily the end goal. We want to make sure they're healthy and safe. And again, things with media that maybe show, that a lot of these cases result in a guilty in court or something, shows like, Law and Order or things, can be really hard because it's sometimes the things that are shown in the media are not what we're experiencing in real life. And sometimes these patients, do not want to be re-traumatized in court and do not want to get up and tell a bunch of strangers what happened over again. And so we do want to respect that. And so we don't want to push our goals on the patient. One thing in my practice I've tried to do is, ask the patient, what are your goals for today? Maybe their goal is not to get evidence collected. Maybe their goal is not to report to police. Maybe their goal is not to, do certain things. And so I can't impose those on them. I mean, part of informed consent is making sure that we still do really good education of the patient. Here's the pros and cons of doing this or not doing this so that they can make an informed decision, but ultimately it's their choice.
Did that answer the questions on the pros and cons for the person who asked?
Yes, thank you. That was very interesting in terms of the numbers. I didn't realize so few end up getting convictions.
Yeah, and I've had, I think sometimes too, the way it's described maybe by non-experts, people with expertise in this. I mean, I've had patients come and say, well, my friend or so-and-so told me that this exam was going to be really painful and really invasive and really traumatic. None of that is true. I mean, the whole goal, again, is to restore control to the patient. Nothing is going to be done to them that they don't want to have done. And obviously, if the clinician sees that the patient is in any sort of pain, things are stopped, we reevaluate. But yeah, the whole goal of this is to not re-traumatize patients. So it's really important in how we explain this as well to patients. We always want to connect them right to someone who does the work to explain it. Because we certainly don't want patients to get misinformation or be scared. And so I'm always delighted when someone found our number on Google and called first and asked questions to make sure, is this going to hurt? Or my friend said this, so we can help to, mitigate a lot of that. Ultimately, if the patient just wants to talk, we can do that too. We don't, we're not going to hold them down and do anything.
we have any other questions from our audience? In the chat, or feel free to unmute.
Well, I wanted to thank you so much and all the panelists for putting this together. I really appreciated the information you shared today, and also the format, so engaging. So I just wanted to thank you and congratulate you on finishing up your MPH degree as well.
Yes, thank you very much. And I have learned so much through this project and this webinar, and from Sergeant Prestel and Christine. It really does take a large community to wrap around survivors of sexual assault to help them reach their goals, their self-determined goals, and give them their power back so they can be safe, healthy, and find justice in their lives.
Thanks so much. I think we can end the recording, and thank you all for coming.